Hello, welcome everyone. It is so great to see so many advocates, so many friendly names popping up on the screen. Thank you so much for joining us tonight for our second installment of our three-part series, Why Are Healthcare Costs in the US and Minnesota So High? We are joined tonight by Kip Sullivan and Ann Jones, who will be popping up on your screen in just a moment. Before we get started, I just wanted to welcome everyone. My name is Jen Crawford. I am the Executive Director for PNHP Minnesota. Tonight we are on Zoom, and if you have any technical questions at all this evening, please feel free to put those in the chat. There's a button that says chat down at the bottom of your screen. Technical questions will go to me and I'll try to help you out. We are going to be doing Q&A with our presenter tonight. If you have a question for Kip, please feel free to hit the Q&A button at the bottom of your screen and you can type those questions in there at any time. We will be taking questions at the end of the presentation. So it is after 6:30. We're going to get started right away. A lot of content this evening. So starting us off is going to be Ann Jones. Ann is a retired RN and she is the Vice Chair of Healthcare for All Minnesota. So take it away, Ann.
Hello, welcome. Thanks a lot for that introduction, Jen. Can you, of course, doesn't show up on my screen, just make sure that we are recording. And I am going to start out this evening by just telling you a little bit about what we have in mind. And I would also like to introduce Judy Barton, our new Healthcare for All Minnesota Administrative Support. Hey, Judy, would you mind going on the screen for just a minute and let people meet you?
Hey, everyone.
Joining us for our first education and outreach event. Thanks, Judy. Very busy learning this new role. As Jen said, I'm a retired registered nurse. I'm going to talk about the purpose of this series of 3 talks by Kip Sullivan, including just a couple of slides on cost, quality, and access to our healthcare system in the U.S. under our current financing system, and then I'll turn it over to Kip. He has a little over an hour of information for us. This is a pretty complex topic. We will have some time for questions after his presentation, and you will have copies of the slides following this session, and we are recording. So I have a few announcements at the very end and informational slides as well, and 2 calls for action for you. And then Jen will end with a wrap up. So first of all, this program is a combined effort of the Healthcare for All Minnesota and Physicians for a National Health Program Minnesota Education and Outreach Committee and the Legislative Relations Committee. The purpose of that committee is to monitor and analyze current and proposed legislation related to cost, quality, and access to healthcare, and work to develop information and training for the public and members of the legislature to reinforce a clear understanding of the factors contributing to the current system, which is key to avoid using flawed assumptions and failed policies to craft future solutions to the problems of cost, quality, and access. This is the second in our series of 3 sessions intended to educate our own activists and advocates, as well as our legislators. I thank you for being here, and as always, please invite others to upcoming sessions. Just a little bit of information about our speaker. We did include some biographical information about Kip in our invitation to this series, but I just wanted to add that Kip has been a relentless advocate for data-driven, policy-oriented approach to healthcare payment reform, literally for decades. And he has contributed immeasurably to the rigor with which proposals for change are viewed, including with the One Payer States organization, of which Minnesota is a member, and our own Healthcare for All Minnesota Legislative Committee members and members of our state legislature. Just a little bit of basic information before we go into our program. We've got a system in this country that costs too much, does too little, and leaves too many people out. For those of you who are not, who don't live and breathe this information every day, I'll repeat that our healthcare industry currently consumes almost 18% of GDP, which is 1/6 of a $21.5 trillion economy. And yet, even after passage of the ACA, which was a major change and improvement in our healthcare financing system in 2010, millions of people in this country still lack health insurance coverage, are entirely dependent on public services, or go without. So total health spending in our country right now is $3.8 trillion per year. That's the most recent information from CMS as of 2019, or $11,582 per person. Health spending in Minnesota was $47.1 billion in 2016, projected to double in 10 years. How we currently finance healthcare is simply a patchwork that really adds up to what is known as what we call a multi-payer system. It is not a system at all. It's a patchwork with a lot of holes in it. We have tried in this country numerous cost containment strategies. Instead of moving to a publicly funded and administered national healthcare financing system, similar to those in place in most other developed countries around the world, we in the US have tried one after another cost containment strategies in the hopes of containing or slowing the growth in the cost of healthcare. This is the alphabet soup of cost containment strategies that have been tried over the last 40 years. You will recognize things like preferred provider organizations, health maintenance organizations, diagnostic related groups, integrated service providers, accountable care organizations, EIO, based on the belief that Americans overuse healthcare and that making it harder to get will somehow reduce costs, or that fee for service is the culprit. Doctors and hospitals just order too many tests and do too many procedures, and that various capitation schemes or controls will cut costs. So costs, in fact, have just continued to go up. Kip is going to talk about the so-called managed care kind of compendium of cost containment efforts that are currently in place. And then next time, our third session is going to cover this belief that somehow if people just had more skin in the game and just would be better shoppers, somehow the cost of healthcare would surely come down. So this approach, of course, cut costs for the insurance companies, shifts costs from employers to employees, and turns health insurance into catastrophic coverage only, with individuals and families unable to afford actual care due to high out-of-pocket costs, the high out-of-pocket costs of these high deductible plans. So that's for next time. So for now, I will turn us over to Kip Sullivan. And I will exit. Thanks. Kip, you're on.
I have yet to see any faces.
Well, we're in a webinar, remember?
All right, good.
They're there behind the scenes.
All right. I'm going to speak for about 25 minutes. Unlike the last webinar, I won't speak and then show slides and speak and show slides. I'm going to speak, just tell you the history of the failure of managed care. And then I'm going to turn to the slides. The slides contain evidence of the statements that I will have made to you. In our first webinar, we reviewed the history of the debate about why healthcare costs are so high. Let me take just 2 or 3 minutes to review what we talked about for those of you who weren't present at the September webinar. We saw that the participants in this long debate about how to contain healthcare costs fall into 3 camps: single payer, managed care, and high deductible. The managed care and high deductible camps share the same fundamental diagnosis. They think costs are high because Americans get too many healthcare services. The single payer movement believes costs are high because prices are high. And we reviewed the old equation that if you're concerned about about total spending in any sector of the economy, you have to be concerned about 2 numbers: the price of whatever you're talking about and the quantity of sold of whatever you're talking about. Price times quantity yields total spending. The managed care and high deductible camps differ and who is causing all the alleged excessive quantity, the alleged overuse of the system, healthcare system. Managed care camp blames doctors and the fee-for-service method by which they are paid, while the high deductible camp blames quote unquote overinsured patients. And as Ann just indicated, we're going to examine the claims made by the high deductible camp in our November webinar. And we'll also look at how managed care theology has driven up Minnesota's costs. In this webinar, we're going to focus on managed care. It has been far and away the most dominant of the three schools of thought. It has maintained a ferocious grip on the minds of policymakers at the federal and state level for the last 50 years. As I explained in the first webinar, the label managed care emerged in the mid-1980s to refer to the cost containment tools pioneered by HMOs. And those tools were capitation, which means paying on a clinic or a hospital clinic chain or a doctor a fee per patient per year rather than a fee for service. The other tool was limited choice of provider. And the third one was micromanaging doctors, making them report lots of data, making them argue with insurance companies about what services patients can have. You can think of HMOs as essentially insurance companies plopped on top of hospitals and clinics. And as I indicated in our history in the first webinar, the first generation of insurance companies did not own or contract with hospitals and clinics. All that changed with the HMO revolution. The insurance industry, led by HMOs, began to own and or contract with doctors and hospitals in order to control them more effectively from their point of view. Managed care has gone through two phases, 1970 to 2000. 1970, as you recall, is when Minnesota physician Paul Elwood coined the phrase health maintenance organization and persuaded Nixon and the Democrats to see that as the solution to the healthcare crisis. 1970 to 2000, and then 2000 to the present. What divides these two phases is the HMO backlash of the late 90s, roughly 1995 to 2000. Managed care proponents reacted to the backlash by introducing new iterations of managed care that were less visible to patients. They hid the role of the insurance industry. The most prominent of these new managed care iterations was the ACO. Others included medical homes, bundled payments, and pay for performance. I'll refer to the 1970 to 2000 version of managed care as managed care 1.0 and the post-2000 era as managed care 2.0. Managed care proponents these days prefer not to call what they're for managed care. They prefer to call their new iterations value-based payment. Allegedly, value-based payment improves both components of value, cost, and quality simultaneously. Both managed care 1.0 and 2.0 failed, and they failed for the same reasons. They adopted the wrong diagnosis, overuse instead of excessive price, and their solutions were vaguely described, poorly planned, and based on little or no evidence. Despite 50 years of failure, managed care groupthink is as influential today as it has ever been. By groupthink, I mean the fervent, almost religious belief that US costs are double those of the rest of the industrialized world because of overuse caused by the fee-for-service method of paying doctors. And the solution is to subject doctors to financial incentives to reduce care and micromanagement by third parties. When I discuss managed care 2.0, I'll review the most compelling evidence of the power of managed care groupthink. Namely, an awful proposal concocted by the Trump administration to turn the traditional Medicare program into a clone of Medicare Advantage. And I believe you all know Medicare Advantage is the portion of the Medicare program that insures Medicare beneficiaries through insurance companies. All right, why did managed care 1.0 fail? You recall from the September webinar that Managed care got its start when a Minnesota physician named Paul Elwood met with 3 Nixon representatives in the DuPont Plaza Hotel in February 1970. That was 1 month after Ted Kennedy introduced what we would call a single payer bill today. Elwood sold the Nixon reps on the overuse diagnosis with no evidence, and he sold them a solution that he called the Health Maintenance Organization on the basis of no evidence. Now, to make matters worse, Elwood and Nixon's representatives agreed they would not define their solution, the HMO, but they should just instead only state their hopes for it. Here is a quote from one of the Nixon representatives who was present at that meeting at the DuPont Plaza Hotel in 1970, from a history written by representatives of the American Hospital Association shortly after the event. John Veneman was the Undersecretary of HEW, Health, Education, and Welfare. And here's what he said to Elwood and the 2 other men in the room at the time. He said, "Why should we specify how to put it together? Let the doctors, let everybody do it. Let's specify what we want the HMO to do. And we don't give a damn how they put it together. Let's describe the thing by what we want it to do, not how it's formed." Veneman's argument was that if they refused to define the HMO, it would make the HMO harder to attack. And it worked. I don't know why, but it did. The Nixon administration was persuaded. Democrats were persuaded. Essentially, they defined the HMO with vague terms, vague descriptions, such as an HMO takes responsibility for providing comprehensive care to a defined population. It doesn't tell you anything about how they work, whether they're different from a traditional insurance company. To drive home for you how devoid of evidence I don't know if you can see this. This is a paper written by Paul Elwood and some of his disciples. When Elwood and the Nixon representatives broke up at their meeting at the DuPont Plaza Hotel, Elwood agreed to send a memo to the White House summarizing his arguments for why an HMO was good policy, and he published it a year later. And this is the article. You can see there are no footnotes. And here's the last page. There are no endnotes. This is a paper representing Elwood's opinion only. We should do HMOs because I said so, is essentially what Elwood said to Nixon and to the public and to the Democrats who bought it. One last quote here just to drive home what a flimsy and evidence-free proposal the HMO was. Let me read to you a short quote from an article that Yuval Reinhardt, a well-known health policy economist who taught at Princeton for many years and who died just a few years ago. This is what he wrote in the Milbank Quarterly in 1973. He said, "The much touted idea of a national network of presumably competitive health maintenance organizations appears to have been proffered on the basis of intuition or faith rather than on the basis of convincing evidence." He was right on. I don't know why his analysis didn't persuade more skeptics to resist the HMO juggernaut. HMOs, however, despite this inauspicious beginning, did not flop immediately. In fact, during the 1970s and 1980s, they seemed to succeed. They were able to keep their premiums 5 to 10% below those of traditional insureds. And as you can imagine, given the high cost of health insurance, if you keep your premiums 5 to 10% below competition, you're going to get a lot of new customers. And this caused the HMO market share to grow substantially at the expense of the traditional insurers. So how did the HMOs keep their premiums down? Remember, Elwood said they'd do it by keeping people healthy, cutting out unnecessary care, only unnecessary care, and doing lots of prevention that the greedy old fee-for-service doctors just didn't want to do. Initially, the HMOs used 3 methods to grow their market share. First, they enrolled healthier people. Partly it was their own advertising, and partly it was decisions by Americans. Sicker people just didn't want to give up choice of doctor in exchange for a smaller premium. Secondly, they shifted cost onto others. The main shift was onto their own enrollees who, when they went out of network, didn't get their bills paid by the HMOs. And I'll show you a slide indicating that was an awful lot of people. The HMOs saved a lot of money that way. HMOs also shifted costs onto the VA, onto workers' comp. They avoided teaching hospitals, and therefore their share of research costs and costs of educating future doctors. And in addition to enrolling healthier people and shifting costs onto others, HMOs denied care via what is typically called utilization review, which means arguing with doctors about what services patients can have. By the late 1980s, when HMOs had gotten much bigger using these first three tactics, they employed a fourth method, and that was extracting enormous discounts from doctors and hospitals, particularly hospitals. And I'll show you some slides on that in a minute. The efforts of the HMOs to deny care by arguing with doctors and hospitals drove up administrative costs for everyone, insurers and providers, and extracting huge discounts from providers set off a vicious merger cycle that continues to this day. Hospitals began to merge with each other and to buy up clinics in the late 80s in order to create negotiating power commensurate with the power of the ever-growing HMOs. As hospital clinic chains got bigger, that set off countervailing mergers amongst the health insurance companies, and around the vicious cycle went. The two problems that the spread of managed care created, rising administrative costs and rapid consolidation of the entire system, raised prices. It raised premiums, hospital and physician fees, drug prices. The increase in prices more than offset the reduction in the utilization of healthcare services that HMOs and by the 1990s preferred provider organizations had achieved. PPOs was a name given to traditional insurance companies as they began to adopt some HMO tactics, limiting some choice of providers, and above all, exercising utilization review. By the late 1990s, the managed care tactics used by HMOs and PPOs had created the worst of all worlds. Patients were angry about diminished quality and access, and employers were angry about skyrocketing premiums. Managed care 1.0 was over. Now, why did managed care 2.0 fail? Well, to explain that, I have to explain to you how managed care 2.0 was created. It's relatively easy to explain the origins of managed care 1.0 because so few people were involved in its creation, and because the solution, the HMO, consisted of one idea. It's more difficult to explain the origins of managed care 2.0 because so many people were involved and the quote unquote solutions were more numerous. By the time managed care 1.0 failed in the late 1990s, it was fervently supported by an enormous informal coalition of large employers, academics, foundations, and most importantly, virtually the entire health insurance industry. I should say it had been supported by this coalition. This informal coalition did not meet in a hotel room to plot their response to the HMO backlash, as Elwood had met with 3 Nixon representatives in a hotel room in 1970. And they did not issue a manifesto, or even a few of them, declaring overuse to be the problem and a simple managed care scheme to be the solution, as Elwood and his disciples did. But we can be sure that this coalition clung to the same diagnosis, overuse caused by fee-for-service, and the same basic solution, financial incentives and micromanagement, because they said so often. We have to infer, however, the lessons managed care advocates learned from the HMO backlash. We may infer from their behavior and a few isolated statements that the lesson they drew was that the tactics used to influence doctors and hospitals had to be less visible to patients than the HMO tools, special utilization review, and limits on choice had been for the previous 30 years. The Accountable Care Organization, the ACO, the premier example of so-called value-based payment, illustrates the thinking of managed care advocates after 2000. It was similar to the HMO, but with three important exceptions. First, people were assigned to it. They didn't enroll. Second, they were not required to stay within the ACO network. If you buy the first requirement, they're assigned, then it makes sense not to require them to stay within the network because they don't even know they're in one. And the third difference between ACOs and HMOs in the beginning was that ACOs split profits and split losses with another insurer, with Medicare or Humana, or here in Minnesota, the Department of Human Services, which has set up some ACOs within our Medicaid program. But doctors and hospitals would still be exposed to financial incentives and micromanagement by their ACO. Now, obviously, if people don't know they're in a network of doctors calling itself an ACO, and they're free to go outside the ACO network, there will be no ACO backlash. If ACO doctors or hospitals deny necessary care, patients will express their anger at the doc or the hospital, and not the ACO, perhaps not the ACO, and certainly not the insurance company that's further upstream. Now, to people who are not immersed in managed care folklore, this sounds irrational, but this is an accurate description of the ACO. As is the case with the HMO, only way to understand something as poorly defined and as illogical as the ACO is to go back and describe its origins. It just helps to be in the room and ask yourself, what were these people thinking? And I'm going to tell you what they were thinking as best I can. The ACO was invented at the November 9, 2006 meeting of the Medicare Payment Advisory Commission, MedPAC. Congress had 1 year earlier asked MedPAC to propose a method to reduce the cost of the traditional Medicare program. The traditional Medicare program was far more efficient than the Medicare Advantage program. Congress should have focused their attention on the vast overpayments to the insurance companies in the Medicare Advantage program. And we're going to talk a little bit about that in the November webinar. But under the powerful influence of the myth that fee-for-service causes overuse, Congress assumed overuse was rampant in the traditional fee-for-service Medicare program, and something had to be done about it. And so they instructed MedPAC to recommend a solution. And the invention of the ACO at the November 9, 2006 meeting therefore wound up being remarkably similar to the invention of the HMO at the February 5, 1970 meeting of Paul Elwood and the Nixon representatives we just discussed. The similarities are there were only a few people present. This was not something that welled up from the grassroots. There was never rallies in the streets and on steps of Capitol buildings where people shouted, "What do we want? ACOs, when do we want it? Now." It didn't happen. There was a few people, like strictly top-down decision. Second, the people who invented the ACO assumed overuse was the problem that needed to be solved, and they had nothing to say about price. Third, they defined the ACO based on their hopes for it, not how it would work. Sound familiar? They offered no evidence for their diagnosis or solution. In fact, when MedPAC got around to recommending to Congress in its 2009 report, ACOs, that's when they formally recommended ACOs to Congress, MedPAC already had the preliminary results of a pilot test of the ACO program that CMS was conducting. And those results were showing they were not saving any money and having a trivial impact on quality. MedPAC, quote unquote, defined the ACO with the same aspirational language that HMO advocates used. Quote, a group of providers who agree to be held accountable for the cost and quality of healthcare for a defined population. Accountable to whom? How? What are they going to do to reduce costs? How do they improve quality? Who defines the population? No answers. As was the case with the HMO, Congress endorsed the ACO even though its advocates could not define it, and even though there was no evidence for it. Democrats wrote the ACO into the Affordable Care Act in the early drafts in the summer of 2009, and Obama signed the Affordable Care Act in March 2010. And so this odd proposal, the ACO, went from a couple of people talking about it in a meeting with MedPAC to the law of the land in about 3.5 years. Democrats left it to CMS, the Centers for Medicare and Medicaid Services, the agency that runs Medicare. Democrats wrote the Affordable Care Act, the provisions authorizing ACOs in the Affordable Care Act. They wrote it and left and in a way that left to CMS the job of describing how Medicare beneficiaries were going to be assigned ACOs. Can you imagine being given that job? This is where it gets strange. CMS adopted a two-step process. First, they assigned beneficiaries to primary care doctors based on which doctor they had seen the most over a 2 or 3 year period. If I saw only one primary care doctor, I was assigned to that doctor. If I saw Dr. A, say, twice and Dr. B once, then I was assigned to Dr. A. And if I didn't see anybody, then I wasn't assigned to a doctor. But in the case of Medicare, a sizable majority of Medicare beneficiaries see a primary care doc once a year. That's at least once in a year. The second step that CMS devised was this: if the doctor I was assigned to had joined an ACO, I was assigned to that ACO, and I wouldn't know it. Now, not surprisingly, given all of this, no definition, no evidence, this crazy method of assigning people to ACOs, none of the 4 ACO programs that CMS has implemented have worked. They're not saving money. They have mixed and trivial effects on quality. And ditto for the private sector ACOs that the insurance industry began to set up almost immediately after the Affordable Care Act was passed. Now, ACO proponents have reacted to the failure of ACOs basically by saying ACO should be more like HMOs. It's almost like they forgot why we were doing managed care 2.0 and the HMO backlash. They're arguing that we should shift, that CMS and the private sector insurers should shift all risk onto ACOs. That is, ACOs would eat 100% of the losses and take home 100% of the profits. They would be paid a premium, just like insurance companies. And just like insurance companies, they keep all the profits and eat all the losses. And the other argument ACO proponents are making, the excuse they're making for ACO's failure, is that patients don't identify with their ACO. They can't even tell you what an ACO is. And so they're arguing for allowing physicians in ACOs to start persuading Medicare beneficiaries to do kind of a backdoor enrollment. You might sign a statement attesting that you are my primary care doctor and I will try to see you for all of my services, or something like that. This part of their proposal is very poorly defined. Now, this is almost exactly what the Trump administration proposed in 2019. They proposed a program in which ACOs would be renamed direct contracting entities. Now, why rename? I suppose partly because they know ACOs like HMOs were a failure. Now we've got to invent a new label. But I think the most important reason is that the Trump administration in this proposal is explicitly allowing insurance companies now to apply to be ACOs, in addition to hospital clinic chains. So now what do you call them? Hospital providers, insurers? Rather than fuss with it, they just call them entities. So the program is called Direct Contracting Entities, DCEs. And DCEs would be paid a premium per beneficiary who enrolled or was assigned, and they are calling for enrollment. But if people refuse to enroll, they will be assigned. And because they're being paid a premium, the DCEs will eat all losses and keep all profits. and beneficiaries would be forced to join a DCE. DCEs at this point would be indistinguishable from HMOs, and all beneficiaries would be in a DCE/HMO, and presto, the traditional Medicare program would look just like Medicare Advantage, and the goal of managed care advocates of totally privatizing Medicare would be accomplished. I hope you can perceive the straight line I've drawn from Elwood's HMOs to MedPAC's ACO to Trump's DCE. A half century separates them, but they are nearly identical. And they all sprang from the same original errors: the overuse diagnosis and poorly defined evidence-free solutions based on the wrong diagnosis. Price was always the correct diagnosis, and we'll show you a little evidence on that in the slides. If you ask me, what is the single most fundamental reason why managed care failed? I would say it's because its proponents do not respect evidence. They dream up proposals without evidence, and when their proposals fail, they don't admit it. They double down. The HMO becomes the ACO, becomes the DCE. Old wine is poured into new bottles. Now, if I can bring up my slides, I want to give you some evidence supporting what I've been saying here. I want to start. I'm assuming everybody can see this. Ann, do you see this?
Yes, Kip. And if you just want to go to slideshow.
Oh, yes. Thank you for the reminder.
We'll have the slides only. Thank you.
There we go. All right.
Good.
Let me get my marker ready. All right. The first slide I want to show you is on this change in nomenclature, or if you like my wine analogy, the building of a new bottle of wine into which to pour the old wine. This is from a software program that Google makes available called Google Ngram. N as in never, gram as in the weight. And if you plug in up to 3 words, they'll show you how often they were used and when. You see that the phrase managed care, which came to refer collectively to the tools HMOs pioneered, skyrocketed beginning in the 80s as managed care spread, as HMOs spread, and then as traditional insurance companies became PPOs. And look where it peaked. That's about 1999, 2000. That's when the HMO backlash was at its peak. We saw experts declaring managed care 1.0 to be a failure. And whoa, I guess we won't use this word managed care too much anymore. And look at when value-based payment became all the rage, right at 2000. This was when the informal coalition of employers and managed care advocates began to invent things like ACOs. I'm going to just show you a couple of slides from experts saying essentially what I've just told you. Managed care was declared to be a failure by about 2000. Arthur Kaplan taught at the University of Minnesota, then he went to the University of Pennsylvania, now he's at NYU. He's a highly well-known health policy expert. He said to MSNBC in 2001, managed care has failed dismally. I read this to you at the September webinar. This is a similar statement by George Lundberg, who used to be a passionate fan of managed care. He said to the Los Angeles Times in 2001, managed care is basically over, people hate it, and it's no longer controlling costs. This, my mouse gives me trouble. For those, particularly for those of you who weren't at the September webinar, let me just summarize for you the power of the erroneous overuse diagnosis. The cascade, the journey toward failure starts with the wrong diagnosis, that overuse is the problem rather than price, and that the overuse is caused by doctors responding to the fee-for-service method of payment. Now, if that's the diagnosis you get in your head, then you're not going to be thinking about getting rid of administrative costs that drive up price. You won't be worried about mergers that drive up price. You're going to be concerned about reversing the fee-for-service method incentive. And you're going to adopt a solution that subjects doctors to capitation and micromanages them. And if you endorse capitation, then you also have to endorse limiting patient choice of provider, because it's neither logical nor fair to, if Kip picks Dr. Ann Jones as his doctor, and then Kip gets hit by a truck and he goes somewhere else for treatment, and he sends the bill to her. Can't work. So that's what's so compelling about a wrong diagnosis. Well, it's true in any field, but in health policy, if you adopt overuse and fee-for-service, you wind up with this solution, and as we've seen, it failed. Boy, I might want to switch to my laptop if this mouse keeps giving me trouble. You know what? I think I'm going to have to get out of the show and do this manually. This is an example of a managed care advocate, in this case, Andy Jakowski, the CEO of Blue Cross Blue Shield Minnesota, making a classic argument for managed care. You see here that he says in the 70s and 80s, medical journals were loaded with studies. The popular press carried tales about unnecessary tests and procedures. Managed care achieved cost control largely by reversing the financial incentives of fee-for-service medicine. It simply is not true that the medical journals were loaded with studies proving that overuse existed. And it's not true that managed care achieved cost control. It is true they thought they were going to achieve it by reversing the fee-for-service incentive. This is a useful statement from a 2015 article by Roger Feldman at the University of Minnesota, just stating what I'm telling you, that there is a groupthink, there is a consensus that fee-for-service must be replaced because why? It increases the volume of services. And I read this to you at the September webinar. This is an excerpt from an op-ed in the Wall Street Journal by Drew Altman, CEO of the Kaiser Family Foundation, a scrupulously middle-of-the-road foundation, pointing out the obvious, because the health policy elite has focused all of its attention on volume. That's where all the cost strategies are focused. Very few cost containment strategies focus on price. I can't name one, if you ask me. Now, the next several slides may be the most important segment of this entire three-part presentation. The evidence against the overuse diagnosis is overwhelming, and I don't have time to go through all of it with you, but I really want to touch on the variety of it, illustrate the variety of it for you so that you come away from this presentation impressed that it is true. The health policy elite just goofed big time when they decided to bark up the overuse tree. There are four types of evidence that debunk the overuse diagnosis. First is research showing that overuse is limited to a tiny handful of medical services. The second is that there's simply no evidence that what overuse exists is caused by the fee-for-service method. Third is research indicating that underuse is far worse than overuse. You almost never hear this said. But it's relevant because, in fact, fee-for-service causes all this overuse. Then how do you account for underuse in the same fee-for-service system? And the fourth category of evidence is that and this is the most compelling category, Americans use fewer medical services than residents of countries with much lower costs. This is the first category, and I'm going to show you two slides dealing with the same study. It's a study that appeared in the Archives of Internal Medicine in 2012. It was, geez, I'm going to have trouble with this mouse on this slide too. Tell you what, I'm going to shift back to a slideshow since I'm going to have trouble anyway. Now, if this really gets to be a problem, we're going to, now it's working. This is the study published in the Archives of Internal Medicine in 2012. Deborah Korenstein and colleagues looked for over 20 years of research for evidence documenting that overuse exists. Never mind that it's caused by fee-for-service, just looking for evidence that overuse exists. Not that Paul Elwood said it exists, proven that it exists. And they found a few studies, and the majority of those were focused on antibiotics for upper respiratory infections and 3 cardiovascular procedures: carotid endarterectomy, which means cleaning out the plaque in the artery along the neck, coronary angiography, and bypass surgery. Now, the editor of the Archives of Internal Medicine was so impressed by the work they did and how few studies they found that he had to weigh in. And here's what he said. What is most striking about this report is how hard the authors searched for data on overuse of healthcare and how little they found. They viewed 21 years of the medical literature and evaluated 115,000 publications, yet found only 172 articles that addressed overuse of healthcare. This is 2012, more than 40 years after Elwood told Democrats and Republicans overuse is the problem, and the research is still not backing him up. This is the second category of research debunking the overuse diagnosis. There's not a lot to say here. What we're doing is proving an absence. This is a quote from 2 well-known researchers saying that, in fact, a direct association between fee-for-service and overuse has never been established. Now, I'm going to show you very quickly some slides that demonstrate that underuse is far worse than overuse. This is a study that appeared in the New England Journal of Medicine in 2003. Now, pay attention to some of the dates on these publications that I'm going to show you. Let me get my marker up here again, now that it's working. You note the date here, 2003. The American health policy research community really didn't pay much attention to underuse until the late 90s, long after the HMO advocates had gotten away with claiming that overuse was rampant. This was an excellent study. I doubt we'll ever see one as good again. They looked at thousands of medical records of thousands of patients in 12 cities for some 3 dozen medical services, and they found that underuse was 4 times worse than overuse. This study found that underuse was 22 times worse than overuse. And I call your attention to the subtitle, Getting Too Little Medical Care May Be the Greatest Threat to Patient Safety. Note the date, 2005. Definitely an iconoclastic statement in the managed care era. This study found that underuse of tests that look for the origins of chest pain, 7 times worse than overuse. Did I say that right? Underuse was 7 times worse than overuse. Note the date. This is a slide that I put together based upon my research into this question of angiography. We saw that Korenstein et al. Said that coronary angiography was one of the services shown to be overused by good evidence. And I wondered, well, how bad was the underuse? Well, look how bad it is. You can see that the range is 41% to 65% in Medicare Advantage. Now take note of this number. The underuse of coronary angiography in Medicare Advantage was substantially worse than in the Medicare fee-for-service program. Elwood did not say to Nixon and the Democrats, by the way, HMOs are going to worsen underuse. And by the way, I have checked citations on these articles. You see all the dates here, late 90s, early 2000s. Health policy researchers tend to go in spurts. They got interested in underuse on this particular issue 2 decades ago, and they haven't done much since. So this has not been challenged. This is a jaw-dropping study, again, rarely mentioned by managed care advocates. 80% of Americans with free care don't seek care for serious symptoms. Or to put it the other way around, 22% of people with 100% coverage, no out-of-pocket costs, sought care for 5 serious symptoms: chest pain when exercising, unexplained bleeding, loss of consciousness, shortness of breath, and weight loss of more than 10 pounds. So people fall down unconscious, get back up, 80% don't go to see a doctor. This, by the way, will be a useful slide to talk about in November when we're talking about the skin in the game solution. Somehow, skin in the game advocates think patients overuse healthcare. This is not evidence on their side. The last category of evidence debunking the overuse diagnosis is comparisons of utilization rates and prices with those of other countries. And we're going to see that Americans use fewer physician and hospital services than people in other countries that spend half as much as we do. And again, if price times quantity gives you total spending, well, if the quantity number is a little below average, that means the price number has to be much higher to account for high US prices, high US costs. Just a word of warning here. This does not mean that there are no services in the US that are not provided more often than other countries. C-sections is an example. For some reason, the United States and South Korea tend to do a lot more C-sections than other nations. But on average, Americans use fewer doctor and hospital services than patients in other countries. I'll go through these quickly. I can see I'm ahead of schedule here, but I don't want to drown you in data. The US has fewer hospital beds per capita. It's harder to get into them. That's what this discharge number shows. Fewer Americans per capita get into and are discharged from a hospital. And we get kicked out faster. This ALOS means average length of stay. So we definitely use fewer hospital services than people in all these other industrialized countries that spend a lot more than we do. Ditto for doctors. We have fewer of them, and we see them less often. OECD, by the way, stands for the Organization for Cooperation and Development. It was a coalition of US and Western European nations at first after World War II. It's expanded to include some developing nations and other industrialized nations. And I showed you this at the September webinar. The US citizens in the US are far more likely to say, I didn't get medical care or dental care because of cost. And compare total spending per capita in the US to these other countries. Again, note the date. We began to see some research rebutting the myth that US healthcare costs are high because Americans get too many medical services. In 2003, Gerard Anderson at Johns Hopkins, Yuval Reinhardt at Princeton, and a few other scholars published what seemed at the time to be a path-breaking article with this is the actual title of the article, It's the Price is Stupid, reflecting maybe some of their irritation at the persistence of the overuse myth. And you can see their conclusion. The difference in US and other nation costs is mostly attributable to higher prices, and subsequent research has confirmed that same finding. This is research that appeared in The Lancet, a highly respected British journal, reaching the same conclusion. Prices rather than volumes of health services contribute the most to explaining the higher US spending level. And finally, here's an article that appeared in the Journal of the American Medical Association in 2018, reaching the same conclusion. Utilization rates in the US are similar to those in other nations. Prices appear to be the major driver of the difference in overall costs. I'm going to zoom through these next several slides. We're going to send these out. They add flesh to this research you've already seen. They're examples of obscenely high prices for various medical goods and services in the US. Humira, for example, sells for much, much more in this country than in other countries. Hospital charges are much higher in this country, 60% higher in this country compared with other OECD countries. Hospital costs per day are much higher in this country. Knee replacement, angioplasty, much, much more expensive in this country than in other countries. Now, I want to expose you to a few slides that document what I said about why managed care 1.0 failed. What you've seen so far are slides documenting the statement that overuse is not the problem. Excessive price driven by administrative waste and incessant mergers is the problem we should have been addressing for the last 50 years. Now we're going to look at several studies that confirm what I told you about why managed care 1.0 failed. This is a statement by Robert Galvin. He worked for one of the Fortune 500 companies for years, and I think for GM or GE, one or the other. And in the course of his employment there, became a real expert on health policy and began to write frequently. And in 2006, he said, we still do not know conclusively to what extent traditional managed care actually saves money. Now, this research, I think, is really fascinating because you remember, earlier we saw that Deborah Korenstein and colleagues said coronary angiography was one of the few services that were shown to be overused by solid evidence. Now, here's a study published in 2013 that found similar rates of overuse of angiography in Medicare HMOs and in Medicare fee-for-service. So whether you're talking HMO doctors serving Medicare patients or fee-for-service doctors, they were both overusing angiography by about 13%. Now, let's go back and look one more time at this slide I've already showed you. Remember this? Medicare Advantage plans were worsening, were causing more underuse of angiography than were doctors treating Medicare fee-for-service patients. So if you look at these two slides, same rates of overuse between HMOs and fee-for-service, but different rates of underuse, far worse under the tender mercies of managed care. What this limited research indicates is that the HMOs were not better at reducing overuse, but by God, they were better at aggravating underuse. I really wish we had a lot more research like this on mental health, maternity care, comparing overuse and underuse for both Medicare fee-for-service and Medicare Advantage doctors. I remember Kaiser Permanente was the poster child, the big HMO out in California. Remember, HMOs are basically insurance companies that have combined with hospital clinic chains. This is research done in 2015 by Lawton Burns at Wharton at the University of Pennsylvania, Jeff Goldsmith at the University of Chicago, highly respected, somewhat conservative economists. They looked at 30 years of research and found virtually no measurable benefits of putting health insurance, hospitals, and physician services under the same structure. This is, I'm going to show you now some slides that document what I said to you in my opening, that HMOs lowered their premiums by enrolling healthier people, not paying for services rendered out of network, and using their market power to extract big discounts. Here's the result of a literature review published in 1995, and you see an unequivocal conclusion. This review concludes that all health plans, HMOs and PPOs, which restrict an enrollee's choice of provider, enjoy favorable selection among both the non-elderly and elderly population. Again, favorable selection means you get healthier than average enrollees. Here's some research. I wish there were a lot more of this. For some reason, the American health research community just didn't do it. But here's some limited research on how extensive out of HMO network use has been. The Health Insurance Plan of New York was an early HMO. Research indicated that their enrollees got 37% of their surgical operations outside the plan. Kaiser Permanente enrollees received 14% of all physician services outside of Kaiser. This last one, a 2013 study, health insurance plans with provider networks, 8% of the people who answered a survey used an out-of-network physician over the previous year. Can you imagine being in a business where you're paid to take care of all your enrollees and you get to shirk responsibility for this number? No wonder they could keep their premiums low. Did Elwood tell that to Nixon and the Democrats? Oh, by the way, they're going to save a lot of money by driving people out of network, or people will go out of network accidentally, and the HMOs won't pay. No, he didn't. Here's an interesting quote from a book by George Halverson, a name I think many of you will recognize. For many years, he was the chief executive officer of Health Partners here in Minnesota. And in 2003, he went out to become the CEO of Kaiser Permanente, the poster child for HMOs. And George Isham was a VP at Health Partners. And they wrote a book together, and it was entitled Epidemic of Care. Now, if you were an HMO CEO, isn't that the title you'd pick? We're awash in overuse, folks, and we're going to put it on the title of our book. But interestingly, the two Georges said this about how the HMOs save money. They said HMOs negotiated deep discounts, 30 to 50% in many cases. These discounts cut health plan costs to the point that most HMOs could significantly underprice the traditional insurance products. Well, no, you know what, Sherlock? You get discounts like that, you can underprice pretty much anybody. Now, here's some specific data on HMO behavior in the Twin Cities. I want you to just focus on the 1990 column here. We don't have time to get into the other two. And I want you to look at the HMO and all of their payer numbers. In 1990, HMOs were extracting 37.6% discounts from Twin Cities hospitals. And the other payers, Blue Cross, Prudential, American Family Insurance, they were only getting 3% discounts. Why? Because the HMOs by the 1990 had gotten big. How? Cost shifting, denying care, and now they were big enough to extract discounts. And boy, did they extract big discounts. Well, if you're a hospital and you give up discounts like this to a 1,000-pound HMO, you're telling yourself, I can't do this in another round of negotiations. I'm going to start merging with other hospitals and buying up doctors so that I can come to the negotiating table next time with a lot more power. And that's what happened. Merger madness broke out. It got worse in the late 80s and became severe in the early 90s. This is research that documented what happens in markets where HMOs grabbed a lot of market share from traditional insurers. And you see the conclusion here in blue. Higher levels of local managed care penetration are associated with substantial increases in consolidation in hospital and physician markets. And what happens when consolidation occurs in any market, be it dog food or beer or healthcare? They have the power to jack up their prices. And by the way, demand lowered wages from their workers. So it was these two cost containment tactics that drove up prices. Administrative costs soared for both the insurance and provider sectors, and mergers increased during the 80s and exploded in the 1990s. I showed you this slide last year. Now let's just do a pop quiz. Well, let me first explain the slide. The gold bar shows you the growth in the physician workforce from 1970 to 2016. This blue-green mountain shows you the growth in the employment of administrators, clerks, managers. Now, let's go back to 1970 where this starts. What happened then? That's when Paul Elwood was meeting with Nixon's reps and selling them on the overuse diagnosis. Go to 1972, what's happening? Nixon and the Democrats have been persuaded to insert HMOs into Medicare. And that's a tiny tumor at the time, but now it's a vast tumor called Medicare Advantage. Go to 1973, what's happening? Nixon and the Democrats have now enacted the HMO Act of 1973, which subsidizes and encourages the formation of selling of HMO products to the non-elderly. Move forward slowly. Now we see HMOs using the tactics I told you about, cost shifting, denying services. Now they're getting bigger and bigger. Now they're extracting enormous discounts. And now everybody in the insurance industry wants to utilize HMO cost control tactics, particularly utilization review and limited choice. And boom, we get the explosion in the growth of managed care, of administrators, thanks to the spread of managed care tactics. Now, this next slide really ought to irritate you. It looks closely at what happened to hospitals during this era from about 81 to 93, just before everything went to hell in a handbasket. You see here the changes in full-time hospital personnel between 81 and 93. And you see that primarily because of a growing population, total workforce increased by 11%. But look what the hospitals did under the onslaught of managed care. They cut nursing by 7% to make room for a 46.5% increase in managers and paper shufflers. And they had to charge for that. We'll talk more about this briefly in November when we talk about overpayments to Medicare Advantage plans. Just note that even the biggest insurance companies, which you think might have the lowest overhead due to economies of scale, their overhead is on the order of 16 to 20% of their premium revenue. So in other words, you give Aetna $1 worth of premiums, they hang on to 20 cents to run their shop and pay out 80 cents to doctors and hospitals. Compare that to the traditional Medicare program, 2% overhead to run their shop, they pay out 98 cents to doctors and hospitals. We're going to discuss this problem, Medicare Advantage plans, in a little more detail in November. I want to turn now to evidence documenting what I said about managed care being bad for patients. This is a study that appeared in the Journal of the American Medical Association in 1996. It found that elderly patients treated under Medicare, for them, declines in physical health were more common in HMOs than in fee-for-service plans by a whopping 54 versus 28%. This is the title of an article that showed that Medicare HMOs, by the way, note the title here, the year 97. In 97, Congress in its infinite wisdom decided to allow all kinds of insurance companies into Medicare, not just HMOs, but a lot of the research then and for a few years after referred to Medicare HMOs. This article demonstrated that Medicare HMOs would tend to drive out their sickest, and the sickest would then leave the HMO and go back to fee-for-service Medicare. You see the title here, the revolving door, the healthy go in and the sick go out. These are the results of a study I published in 1999 in the American Journal of Public Health. I did a literature review. It's important to state for all the grief I heap on HMOs that neither I nor anybody else that I know wants you to believe that HMOs harmed every patient they got their hands on. You see here in this study, once in a blue moon, they actually did improve quality of care. A lot of the time, the quality of care between the quality of HMO care was equivalent to fee-for-service care, but in almost half the cases, it was worse. I'm repeating here what I told you in the opening. There was a similarity between the invention of the HMO and the ACO. The ACO was based on the assumption that overuse is the problem. It's invented by a few people on the basis of no evidence. It's defined by aspirations, provoke mergers, and it failed to cut costs or improve quality. I'm going to run through just some of this evidence for you. This is an excerpt from the transcript of that meeting where MedPAC adopted the ACO. Elliot Fisher was the expert they brought in from Dartmouth to make the case for the ACO. And you see here, he says, we need ACOs because these places, meaning hospitals and nursing homes, are churning patients from hospital to acute care to nursing home back to hospital. That is just cynical. There is no evidence for that suggestion. Yes, I don't doubt that sometimes it happens, but to base an entire policy on that is reckless. Here is an excerpt from MedPAC's June 2009 report to Congress. MedPAC really was the primary advocate for ACOs after that November 9, 2006 meeting. And you can see the classic argument that you would think they were arguing for HMOs. You have to overcome the incentives in the fee-for-service system to drive up volume. Volume's a problem. We're not uncertain about this. Volume is the problem. Get the point? And here is Fisher, often called the father of the ACO, because he was at that initial meeting with MedPAC. Here's his criticism of the current fee-for-service system. He says it's based on volume and it encourages overuse. The definition of the ACO is vague or vaguer than that of the HMO. ACOs, here's a quote from Mark McClellan, who was Bush's FDA director, along with Fisher. They say the ACO is a group of providers. Now remember, under the Trump proposal, they're going to add insurers in here. But the ACO began as just something for providers to do, who are jointly held accountable for achieving quality improvements and reductions in the rate of spending growth while caring for a defined population of patients. Again, who will hold them accountable? How? When you hold them accountable, what are they going to do to quality the doctors aren't doing now? Who knows? This is an excerpt from a report in October 5, 2010, just a few months after the Affordable Care Act was enacted, from Kaiser Health News, saying that ACOs are just a concept for now, not a bad description. This is a statement from the RAND Corporation saying, at this point, we still don't know much about ACOs. This is an interesting statement by a contractor hired by CMS to evaluate the Pioneer ACO program. They said the ACO treatment is not a prescribed set of activities or interventions, rather it is a financial arrangement. Boy, try to evaluate that. Here's my favorite definition of the ACO. The Minnesota Department of Health hired IBM and KPMG to interview some ACO managers and doctors on the progress of ACOs in Minnesota. And one of the docs said this: ACO modeling is not an end state. The path is not defined. The end state is not known. Boy, you'd think we were discussing black holes. I won't stop here. We'll send this out to you. This is a useless description of the ACO from Section 1332 of the Affordable Care Act. This is a statement to the slide showing you the insurance industry got serious about setting up ACOs almost immediately after the Democrats passed the Affordable Care Act. This is a statement indicating that the Affordable Care Act endorsement of ACOs set off a growing frenzy of mergers. This is an example of what happened. Immediately after the ACO fad began, hospitals began buying up doctors like mad. Why? Because that's how they get people swept into their ACOs. And this is research from a study that I published in August with Jim Kahn, showing that ACOs are not saving any money. And I think I'm at the end here. Oh, a couple more. This is from a report from MedPAC. See the date here, just last June. ACOs are not improving quality. The research indicates mixed results, small improvements in some studies, no impacts in others, slight worsening in others. And that is the end of the show. And I think it's time for questions.
So thank you, Kip. It is really hard to argue that we should keep doing what we're doing. But hearing all that, so Jen, you want to go to the list of questions so far?
Wonderful. So our first question, it comes from one of our attendees. It says that the health freedom folks are rallying loudly these days. Can we do some PSAs around the fact that the Minnesota Health Plan recognizes the importance of including complementary and alternative care. So, Anne, I don't know if you have any feedback on this as well.
So maybe the attendee would like to clarify. I don't know if that has to do, there's a lot of noise about healthcare freedom related to the push to ignore or refuse to conform to some of our COVID-19 precautions and vaccines. I think this attendee mentioned complementary therapies. Public service announcements have kind of gone away with since the Reagan era. It's really hard to get anything unpaid on media. So we really have to just educate people about the Minnesota Health Plan, which does actually cover non-traditional healthcare therapies, or does propose to cover.
And so does Jayapal's bill.
Yeah, and I don't know if that answers the question for that attendee. There's kind of hard to distinguish between the noise around opposition to public health measures right now and then complementary therapies.
But there's nothing, I should add to that question, there's nothing in any single payer bill I know that says, oh, and by the way, vaccines are mandatory.
No, that's public health.
That should not be a reason for anyone to object to single payer.
Yeah. Hillary.
Go ahead, Anne.
Hillary's commenting that the slide on underuse for 5 conditions is from 1986. Is that still current?
Is that the slide? I think that's the slide from the RAND study on 80% of people not getting care even when it was free for serious conditions. And I know you can't answer me, so I'm just going to assume that the answer is yes. And the answer is that study has not been replicated because it was so expensive to do. What they did was to put several thousand people in 3 arms. One arm was total free care for 3 years, I think it was, or 4 or 5 years. Another one was modest co-payments, and a third one was big co-payments, and they wanted to watch people's behavior. So the answer is that particular study has not been replicated. I've seen one other study indicating that Canadians who have free knee replacements and a hip replacements, only 9 or 10% of them who qualify for it and wouldn't have to pay a dime got the knee replaced or the hip replaced. I wish there were more research like this, but this is an example of the bias within the health policy community. It doesn't help promote the main narrative that overuse is the problem. And we just don't do a lot of good research on it.
All right. A clarification question. Can you just quickly explain the comparison of the percent of underuse and overuse for the same entity? The question says, seems like the numbers don't match. Seems like there must be some other way they're being assessed.
What the best of the studies was that RAND study done by McGlynn et al. Published in the New England Journal of Medicine. And they looked at patient medical records, and that study, I don't think the study, that study did not say, and by the way, were the patients served by managed HMOs or non-HMO doctors. And so, yes, you could find that a patient at the same, the patients at the same clinic, some might have been simply didn't get care they needed, and others got more care than they needed, and it could have been the same doctor, the same clinic. So I don't find that particularly hard to understand. medicine is not physics. It's part science, part art. I think to answer what it occurs to me, the questioner is asking another question. That is, when we compare, that Commonwealth study found that both HMO doctors and fee-for-service doctors both used angiography by 13%. And then I called your attention to another study done at a different time on different providers, which found that the Medicare Advantage doctors were causing substantially worse underuse of angiography than the Medicare fee-for-service doctors. So they were different providers at different times. I hope that answers the question.
Thank you. We have a slew of questions coming in. Before I ask the next one, I just would like Kay, who typed a question in the chat. Could you just clarify, are you on Medicare Advantage? I'm sorry, traditional Medicare. Could you just clarify your question? But our next question is from Mark. Mark says, what do you see as the incentive difference between doctors being employees of ACOs or doctors being employed by clinics funded by global budgeting under a single payer plan?
Could you give that to me one more time?
And actually, Kip, if you click on the Q&A at the bottom of your screen, if it's easier for you to read the question, should be the first one. Mark, yep.
What do I see as the incentive difference between doctors being employees of ACOs or doctors being employed by clinics funded by global budgeting under a single payer plan? Clinics will not be funded by global budgets under single payer. Only so-called institutional providers will be funded by budgets. And they're called global budgets because they will include both an operating budget and a capital budget. So that applies under the Minnesota Health Plan to nursing homes and hospitals. Under Pramila Jayapal's bill, she applies it to a wider definition of institutional providers. Clinics will be paid fee for service. So I hope that answered the question. The question assumes something that isn't going to be accurate.
All right, thank you. I believe Mary was next. Mary asked, the Medicare Advantage promoters are already sending letters. They sure are. Holding sales seminars and actually handing out Medicare Advantage literature to patients as patients sign in for appointments. Open enrollment starts tomorrow. How can we possibly stop this juggernaut? It's a big question.
Excellent question. And we've got to stop it. We both got to stop the Trump DCE plan because that will privatize traditional Medicare. And we have to stop the overpayments to Medicare Advantage plans because if that doesn't happen, they're going to take over all of Medicare, maybe even before the DCEs get to eat it up. We're going to talk more about this in November. It's important to understand how Congress wound up overpaying first the HMOs, and then after 1997, all the insurance companies got their nose into the Medicare tent. At this point, if I were the czar, I'd wave a wand and say no more overpayments for Medicare Advantage plans, and they'd leave the market, they'd leave Medicare in a heartbeat. But we'd have to persuade, I don't have a magic wand, you don't either. We'd have to persuade Congress to do that. And at this point, we're in a bind. The insurance companies would go to their constituents, and we have a lot of them here in Minnesota, and say, look what these nasty people are up to. They want to take away all those benefits that Joe Namath promised you in the advertising you just saw. And Congress will resist. I think the first thing we should do is to enact the proposal that Bernie Sanders and Pramila Jayapal came up with earlier this year, which is to extend benefits to fee-for-service Medicare that are now being offered and paid for by overpayments by the Medicare Advantage plans. That won't stop it, but it will certainly take away a huge incentive for people to be lured out of fee-for-service and into Medicare Advantage. So we should I don't know that Biden, the Democrats, are going to pull it off, but we really should lower the Medicare eligibility age to 60, and we should give Medicare beneficiaries at minimum eye care, dental care, hearing care. I would love it if we extended it, all the goodies that the Medicare Advantage plans are now offering to their enrollees. But it's a hugely important issue. I'm not suggesting we don't take this overpayment issue. You've got to take it on head on. I just think it's a huge fight, given how long we've waited to address this enormous tumor within the Medicare system.
Yes. Thank you, Kip. And I think that is a great segue into your comments, and then the questions from Diane about her question about, is it probable that Medicare will be totally privatized during the Biden administration? And Kay, your question about you finding out you're in an ACO, that all leads us right into our message from Anne to wrap up our evening. But Kip, thank you so much for joining us, for your amazing presentation. And Anne, if you want to share, perfect. Yes, I think now is a good time to talk about what we can do next as advocates.
Yes. Are you seeing? So just a couple slides that I always share about information. Knowledge is power, and the more you know. As you can see, and thank you again, Kip, this is complicated. If this were easy, we would have fixed it by now. We are decades into a situation that is very complicated, is not serving us well, is not saving money, and is not covering everyone, which just makes our job as advocates important, but challenging. So again, here's some resources for the solution we support and prefer, which is single payer, improved Medicare for all, either state-based health plan, hopefully a national health plan. This is the slide that just talks about the dual track toward a national health plan with some bill numbers. There's the Medicare for All Act of 2021 was reintroduced in March of this year. We hope to see the Senate companion bill yet this fall. This will be in your slides, a couple slides about what's in the Minnesota Health Plan and what's in the National Health Plan, the importance of grassroots support for pushing our legislators and members of Congress toward change. We have seen that even Democrats, who we kind of like to think are a little bit more informed on health policy and a little bit more with us on reform, are really kind of misinformed and all in on Medicare Advantage. They have somehow kind of drunk the Kool-Aid on the current, that the solution is embedded in some of these managed care strategies, and we need to disabuse them of that notion. We're going to have to do a couple things. I've got slides on a lot of learn more, get really grounded in what's going on and what the preferred solution is, and have a lot of conversations both with friends, families, neighbors, the public, and our elected officials. Before I get into the two calls for action that we have this evening, I've got a few announcements. One is that we ask that you like, follow, share, and post on our Healthcare for All Minnesota and PNHP also, but Facebook, Instagram, and Twitter accounts. Social media may not come real naturally to all of us, but we are trying to put out more information on social media as a way of influencing the public, especially in this era of limited in-person events. So the addresses are up there on the screen for you. Our calendar, hca-mn.org, has information about other meetings and events. This was the second in a series of 3 talks by Kip Sullivan. Session number 3 is coming up on Thursday, November 11th at 6:30, a month from now. And then there is an event sponsored by the Sisters of St. Joseph Healthcare for All Task Group. I happen to be a member on that committee. And one of the speakers is one of our big Healthcare for All Minnesota board members, Dr. Jim Hart. And it's going to be, it's called Public Health, Why It Matters, especially timely in this era where we have seen that a lack of a robust, coherent, fully functioning public health system has left us really unable to respond as well as we could have and should have to the COVID-19 pandemic. So Dr. Jim Hart is speaking. There's another woman speaking who is a consultant on healthcare equity. And then there will be students from the College of St. Catherine School of Public Health. Our two calls for action this evening have to do with.
Yeah. Sorry, and just one second. Will you click from current slide? Sorry, you're.
Oh, I'm sorry.
It's okay. It's all right. It's just
that way you could see better.
Big for us. Thank you.
I can see it. What's better? Right. All right. Yeah. So the link for signing up for that event on October 29th. So that's next Friday morning, the 29th, is on the screen, and you'll get that in the slides. And then our call to action about the Medicare expansion that Kip just talked about, expanding Medicare, lowering the eligibility age, and expanding benefits. This is a current proposal as part of the American Families Plan. You're hearing all kinds of news about the Reconciliation Act, or the human infrastructure it's being called. It's also called the American Families Plan. The proposal is to include in that legislation lowering the Medicare age to 60, expanding benefits to include hearing, dental, and vision, capping out-of-pocket costs, and big one, allowing Medicare to negotiate drug prices. The numbers to call your congressperson and our two senators are on the screen here, and I'll also be in the slides. We do need to lobby our members of Congress. So Dean Phillips supports this, Betty McCollum and Ilhan Omar, but we don't, I believe Angie Craig and CD2 is not on the letter that supports this. Senator Tina Smith does support it. However, there's some evidence that she doesn't exactly understand the difference between Medicare expansion and Medicare Advantage. So that's a concern. So I think it's worth a call to Senator Tina Smith. Senator Amy Klobuchar has only come out in support of negotiating drug prices, so she really needs to be pushed on this. And then there's a lot of debate about what's actually going to be in that American Families Plan. So anything you can do to support parts of this program would be helpful. And I'm sure that you're monitoring this, and we need all Democrats on board. That's really a concern. And then the other one that Kip just talked about is this new and very serious threat to traditional Medicare. So as if Medicare Advantage were not already a threat to traditional Medicare, because it is draining the Medicare Trust Fund. Newest information is that Medicare Advantage, the commercial insurance industries that are the subject of all the ads on TV and the blizzard of mail that you're getting in your mailbox if you are Medicare age, has documented approximately $140 billion in Medicare overpayments over the past 12 years. It is costing us a lot of money and draining the Medicare Trust Fund. A new threat on the horizon that could end Medicare as we know it, and health policy and single payer advocates are very concerned. These so-called direct contracting entities, or DCEs, also known as Global Professional Direct Contracting, or GPDC, is a scheme crafted during the Trump administration that authorized the Centers for Medicare and Medicaid Studies, CMS, to test a process that would transfer Medicare beneficiaries to private health insurance companies or investor-owned and controlled provider firms. That means profiteering without their knowledge or consent. These entities would then be authorized to bill Medicare for services provided at whatever rate they come up with based on the coding of the service, their coding. This would inevitably accelerate a billing system that has already resulted in billions of dollars in overpayments from the Medicare Trust Fund and further deplete its ability to cover beneficiaries. So we ask that you go to the PNHP website, and I'm showing it on the screen. I think Jen's going to put a link also in the chat, and show your opposition to this proposal. If you do go to the PNHP website, which is pnhp.org, then just look on the left of the screen, and it says sign our DCE petition. Thanks for that. We're going to be providing more information on this during our quarterly meeting on December 4th. So it's a concern. We need the public to get active on this and be informed. And it was a very under the radar kind of clandestine scheme to privatize what is one of the most popular and most important public programs that we have in this country. So contact information for Kip here and for me, and then I'll let Jen wrap up. We are a little over time, and thank you for your patience in sticking with us tonight.
Yes, thank you everyone for joining us this evening. We look forward to seeing you all back here next month for the third and final installment of this series. That will be on Thursday, November 11th at 6:30 p.m. The link to register for that final event in the series will be included in the follow-up email that you'll receive. That will include slides from this evening. So all of the slides that you've seen, all of that research, and a link to the video that you can share with others and come back to if you have any questions. So we thank you so much for joining us this evening, and we look forward to seeing you back here in November. Good night, everybody.